body is carried forward over the planted foot or stance leg. This is when the foot should supinate or roll out. I'm exaggerating here to see that. If you can pan in, my foot's rolling out. Now my foot is more of a rigid lever. David was not doing this. His foot was still flat. You don't want your foot to be flat in this phase because, like I said, it needs to be rigid to get ready for the heel-off phase of gait, which is the fourth phase. And this rigid lever allows for propulsion, so when you're toeing off, you have a rigid lever and you get more energy. When your foot is still flat, it's still loosey-goosey and it's not rigid, and you lose a lot of energy. And people that pronate too much or pronate in the wrong phase in mid-stance is where they lose a lot of energy, and it's not a good thing. Okay, getting back to David, we already mentioned that he overpronates, or he pronates in the wrong phase. He's pronating during mid-stance, and that's not when you want to pronate, and that can cause a host of problems for us, certain types of people. Not everybody gets these problems, but the trend says that you're more likely to get problems. When the foot's pronated during mid-stance or the wrong phase of gait, it can cause problems at the foot. It can cause a condition called plantar fasciitis, possibly. It can cause knee problems, because if the foot's flat, the knee tends to bend in. It tends to go inward, and then the hip follows suit. So everything follows suit from the foot. So if the foot is faulty mechanics or faulty posture, then everything up the chain is going to suffer. So it's very important that we first correct or at least modify his foot position. And what we do usually is I usually recommend a certain type of sneaker. It's called a motion control sneaker because he's got too much motion. We mentioned earlier that's loosey-goosey. We need to have it lock up in the right phase of gait. So one of the places I recommend people to go to is Marathon Sports. I have no other connection with them outside of sending people there. There's one in Wellesley, there's one in Cambridge, there's one in Boston, and there's one in Brookline, I believe. And there's maybe more, but those are the ones that I know of. And they actually watch you walk. And they can do a little gait analysis or walk analysis and see if you are an overpronator and give you the right footwear. If he's having pain and we still have not corrected that, he's got an issue still, he's got knee or foot, I would say maybe we need to go with an orthotic, something a little bit more aggressive. And that's fabricated by a podiatrist or a foot doctor. And usually they need to see maybe their primary care physician first saying, hey, doc, I'm having problems with my feet. I need to see a foot doctor. And then the foot doctor would fabricate an orthotic, which is a little device that goes in the shoe, in the shoe that he may have already bought. Okay, and then we'll see if that corrects it. Those are the first two things that I would do for that. But we're going to go to the next thing now. We're going to go to an overhead squat test. And David is going to put his arms above his head. Okay, we're on the overhead squat, like I said, and I got since we're just concentrating on the lower body, but what David is doing, he's got his arms above his head holding a dowel, okay, but we're just looking at from the waist down. I just want to show you. We got his feet, if we can pan in, my cameraman can pan in, so we can see these pieces of tape. He's parallel with the tape. His feet are straight ahead. And what we're going to do is we're just going to have him go into a squat position. So once you go into a squat, Dave, and as you can see, David's feet, they're flattening out even further. His knees are bowing in. We call that valgus. And his hip, or his femur here, is internally rotated, causing abnormal forces at the hip, and abnormal forces at the knee, and causing more problems at the foot. Now come back up. Now sometimes we don't know right now if the faulty mechanics, I'm assuming it's coming from the foot, but I don't know that for sure. So one of the ways to determine whether it's coming from the foot or from the hip is to actually have him stand now on a half foam roll. Okay? His heels are on the half foam roll. And we're going to do the same thing. Now go into the squat, Dave. As you can see, everything is corrected now. His knees are in normal alignment, his hip is not internally rotated, and his feet have a little bit of an arch. So we know it's coming from the foot. Okay, come back up, Dave. I'm going to take this off. Okay, what is the plan of action if the problem is coming from the foot in terms of exercise? We already talked about footwear. What is the plan of action for exercise? Well, most of the time, I like to do one-leg standing postures because it really strengthens the muscles of the inner foot here. One of them being, in particular, we mentioned earlier, the posterior tibialis, which is usually weak in most people that overpronate in the wrong phase, like we said. Especially if your feet is flat, we can see that foot is flat, and a lot of times the muscle in the foot, the posterior tibialis, is lengthened, and it actually is weaker when it's lengthened. So we want to do exercises that encourage standing postures on one foot. We also want to stretch the calves. In many cases, they're tight, and also I like to encourage the foam roll. The foam roll is something that breaks up scar tissue, and it can really decrease a lot of scar tissue in the back of the Achilles area and in the calf area. You find a tender spot, you hold it, and then you basically try to get that out. That's going to help increase range of motion as well. Okay, if the hips are causing the knee issue, again, we said earlier, if we put the foam roll underneath it and we still see the knee bowing in the foot flattening out or everting, then we probably have an overreactive IT band, which is a band that comes down the side here, and underactive gluteus medius muscle, which is the side of the hip here. We need to strengthen the gluteus medius muscle, and we need to stretch or foam roll the IT band. Again, the foam roll breaks up adhesions, which occur a lot of times when people's glutes are weak. The IT band takes over in many cases, and that can cause a lot of abnormal forces at the knee and hip, as we mentioned earlier. Another thing I want to mention is that many people do, a lot of therapists, and myself included, and a lot of trainers, do a lot of isolation motions for the gluteus medius and gluteus maximus, like bridging and hip abduction, like lying on your side and lifting your hip up. I think that's good in the beginning, but I think we need to integrate whole body patterns because that's what our nervous system is adapted to. Doing a pattern and a movement which is going to not isolate a muscle, and it's going to actually work the whole kinetic chain from the foot, knee, and hip. So we need to integrate movements like that. Again, it would be like a one-leg standing type of deadlift exercise. Start with small range and then work to a greater range. But that would be a great exercise because it's actually integrating the muscles in the foot, the muscles that surround the hip, and they're working, like I said, in a whole body pattern. That's what the nervous system is more adapted to do. Just some closing comments. Training has definitely progressed in terms of what we know and what we can share with our clients. Just that simple overhead squat test tells us a lot about someone's movement patterns and how we can correct them. And we just touched the surface. We have so much we could do above the hip that tells us a lot as well. And there's other things that I do on my assessment as well, but it's only a 30-minute show. One last thing I'd like to talk about is the core. We hear so much about it. It's become a big buzzword in the gyms today and in physical therapy. If you ask 5 different people, you get usually 5 different answers, but this is the best thing I can come up with in terms of the core. It's kind of a snapshot. But the core musculature is made up of 2 types of muscles. The muscles that are directly attaching to your spine and hips, and I'll get into the other muscles in a second. Those muscles, the muscles that attach directly to the spine and the hips, are built more for stability. So when you move your upper or lower extremities, your core muscles should stabilize your spine and hips for stability. They're built more for holding postures. They're built more for low loads, high volume, and they really are best worked when we're in an unstable environment because they act on reflex. So we shouldn't have to tell somebody to turn their core on. When you're in an environment that's what we call proprioceptively enriched, or a environment where it requires balance, those core muscles turn on. No, you're not going to get a burn like you would if you're watching Tony Little doing those crunches, but you're going to turn on the core. And the core turns on, the deep core muscles turn on in 3 different postures. They turn on differently when we're in a squat position, they turn on differently when we're in a lunge position, and they turn on differently when we're in a one standing leg posture. So all those 3 postures we try to encourage to turn those core muscles on in different ways. We may see deficits in any one of those 3 postures, as well as many other postures. The other type muscles that we already talked about the deep core muscles that attach directly to the spine. The other muscles are more superficial, and they do not attach directly to the spine. Those muscles are built more for movement or mobility. And I see a lot of people working a lot of those muscles more and kind of neglect, unintentionally, the deep core muscles. And to me, that's a disservice to the body because you want to have a stable base before you start getting